Hello there, my name is Paul Lawson. Welcome to my video on what you need to know about proton pump inhibitors, PPIs. I believe that you should have a good understanding of your medications to get the best benefits from them. You should be aware of possible side effects and safety issues to ensure you can act early to prevent problems. With your new knowledge, you should find it easier to work with your doctor on your management plan. Overall, you should feel more confident and in control. Any unnecessary anxiety will be reduced. I will also talk about lifestyle issues which could be altered to help. My video ends with a list of the main learning points. So with this brief introduction, let's move on to the presentation. Now, what are proton pump inhibitors? Proton pump inhibitors are very effective medications which reduce stomach acid and the conditions related to this. They improve symptoms of indigestion, which are due to inflammation and sometimes ulceration. They are very widely used. Since their use was started in the late 1980s, they have been considered to have low side effects and are now allowed in the UK as an over-the-counter medication for limited time use. Examples are generic names first with brand names in brackets: omeprazole, esomeprazole, lansoprazole, pantoprazole, rabeprazole, and dexlansoprazole. I thought it might be useful to explain the difference between generic and brand names. Generic names are the official chemical name allocated to a medication and is unchanging no matter what brand name might be given. This avoids any confusion about what medication you are on. The generic name will always be on the packet, with or without the brand name. Doctors will usually use the generic name. Brand names are given by a drug company who manufactures it for marketing purposes. The initial brand name is given by the company who developed the medication. Because they developed the medicine for a period, they are the only company given a license to sell it. After this, other companies can obtain licenses to make a generic version, provided they can show it has the same efficacy as the original. I thought it would be interesting to give some historical perspective. What did we do before acid-reducing medication? The first acid-reducing medication was the histamine 2 receptor blocker cimetidine in 1976. The first PPI was omeprazole in 1988. Before 1976, there was no medication to reduce acid production. The only medications were antacids. The only treatment for acid reduction was major abdominal surgery, where they cut the nerve supply to the stomach, which in turn reduced acid production. As you can imagine, when cimetidine came along in 1976, it was a revolution in the management of acid-caused conditions. How do PPIs work? They benefit upper gastrointestinal acid-related conditions of the lower esophagus, stomach and duodenum by reducing the amount of acid produced by acid-secreting parietal cells in your stomach. This reduces inflammation and ulceration. Symptoms are relieved, usually fairly quickly, and over a few weeks of treatment, any inflammation and ulceration should heal. When should I take my PPI? A PPI should be taken 30 to 45 minutes before a meal to obtain the best acid-reducing effect. They should be taken at the same time each day, usually once per day, but can be twice per day if advised by your doctor. There are other factors that may contribute to upper gastrointestinal acid problems. The presence of bacteria called Helicobacter pylori was discovered in 1982 to have a strong link. This occurs in 40% of the UK population, although not everyone will have problems. If you have Helicobacter, treating this with a course of antibiotics along with a PPI will be more effective than a PPI alone to improve symptoms, heal ulceration, and also help prevent further similar problems in the future. your doctor can arrange a check for Helicobacter, usually from a small stool sample. A hiatus hernia is when, due to a weakness in the muscle between the chest and abdomen, called the diaphragm, some upper stomach passes through this, allowing stomach acid to irritate the lower esophagus. This may cause symptoms, but not always. Other factors that may contribute to upper gastrointestinal acid problems continued. If you are overweight and have heartburn symptoms, there is evidence that losing weight can improve this. Lifestyle changes to factors such as diet, for example avoiding spicy or fatty foods, carbonated drinks, caffeine, alcohol consumption and smoking can also benefit symptoms. Elevating the head end of your bed may help reflux symptoms at night. Stress is a well-recognized contributory factor. There are several different acid-related conditions. Doctors manage these with the help of clinical guidelines. So what are clinical guidelines? Clinical guidelines are drawn up by senior doctors in the relevant specialties, in this case gastroenterology, based on the evidence from worldwide studies to guide all doctors on how they should manage different conditions. With upper gastrointestinal acid disease, there are a variety of conditions, each requiring a different approach on how to use PPIs. Guidelines describe appropriate doses and durations of PPI use for each of these. Examples of guidelines in the UK are the National Institute for Health and Care Excellence NICE guidelines and the Scottish Intercollegiate Guidelines Network SIGN guidelines. The British National Formulary, BNF, which is the handbook used by all doctors in the UK to enable them to prescribe medications correctly, uses guidelines to create their prescribing information. Using guidelines, how should we use PPIs? Firstly, as required use is advised for occasional symptoms of indigestion, for example, dyspepsia, acid reflux, heartburn, bloating, and also for indigestion associated with courses of oral steroids. Secondly, short-term courses of PPIs, 4 to 8 weeks, are advised for gastroesophageal reflux disease, GORD. This diagnosis is made by your doctor if you have severe or persistent symptoms. No endoscopy is required to make this diagnosis, but sometimes may be advised. Upper gastrointestinal inflammation and/or ulceration shown on endoscopy is also considered as GORD. By 4 weeks of treatment, symptoms will have cleared in most people. If not fully cleared, the course can be extended to 8 weeks, which should deal with this. Endoscopy studies have shown the healing that is associated with the symptoms going away. After the 4 to 8 week course, if any symptoms recur, use a PPI as required. If symptoms are severe and persistent, you may require referral to a gastroenterologist, who is a specialist of disease related to the gastrointestinal tract, who can advise if you are a more complex case who may require longer regular PPI use. Thirdly, long-term use is advised for the following: protection of the upper gastrointestinal tract for patients on long-term non-steroidal anti-inflammatory drugs for arthritis, Barrett's esophagus, which is a severe chronic inflammation of the lower esophagus, a benign esophageal stricture, which is a narrowing at the bottom of the esophagus due to acid damage, which can cause swallowing problems, and finally Zollinger-Ellison syndrome, which is a rare small tumour, usually in the pancreas, often benign, which secretes the hormone gastrin, which is a stimulant for acid production in the stomach. Inappropriate long-term use is a recognized problem. Regular long-term use should only be taken by those who have the conditions where long-term use is advised, or if a gastroenterologist feels a complex case requires this. Unfortunately, patients who are not in these categories often remain on PPIs regularly for much longer periods than recommended. Many people remain in them for months or often years. Evidence shows that this is the case for a significant number of people. If you think you may be on a PPI inappropriately long term, you should discuss this further with your doctor. Another issue that it is important for you to know about is that there is a rebound overproduction of acid when you stop a PPI, which is probably part of the problem with people coming off PPIs. When you stop a PPI after regular use for 4 weeks or more, there can be a period of rebound overproduction of acid, which often causes recurrence of symptoms. This lasts around 2 to 4 weeks and occurs despite the original problem having caused the symptoms being healed. If this occurs, it can be managed by antacids or an alginate until the rebound symptoms settle. A gradual reduction of the PPI may help. A histamine 2 receptor blocker, for example cimetidine, another type of acid-reducing medication, could also be given over this period on an as-required basis. But remember that histamine 2 blockers will also give a rebound effect if they are continued too long. An awareness of this temporary acid rebound is important to understand how best to avoid unnecessary long-term use of PPIs. Now, why is inappropriate long-term use considered to be a problem? Nowadays, we have a better understanding of the risk factors and side effects related to long-term use. The following have been identified: worsening osteoporosis risk, resulting in more bone fractures, especially in the elderly; worsening risk of chest and gut infections, for example, Clostridium difficile diarrhea; unbalancing some body minerals and vitamins such as iron, calcium, magnesium, and vitamins D and B12. If you have a low magnesium, this can also lead to low calcium and potassium levels. Very occasional kidney impairment. Links to an increased risk of stomach cancer and more recently dementia have been raised. In both cases, evidence is uncertain. Of note is that there has been a 50% reduction of stomach cancer in the UK over the past 30 years. This is the period since PPIs were introduced. Also, the studies which showed a slight link of PPIs with stomach cancer were observational, which meant the PPI groups were self-selected to have upper gastrointestinal conditions, which could account for any link. The biggest known risk for stomach cancer is Helicobacter pylori. Most experts agree PPIs are unlikely to be a harmful factor for stomach cancer. Studies for a dementia risk link show varying results. Other side effects. Apart from the specific issues with long-term use described, PPIs are considered to have low adverse effects. They have, however, been associated on rare occasions with a reversible acute kidney function decline, and recognized side effects include gastrointestinal upset, headaches, and skin rash. If you develop a skin rash, you should show this to your doctor. As with all medications, a range of less common side effects may occur and can be checked against the list provided on the information sheet which comes with the medication. If you have developed any new issue which causes you concerns in starting a medication, whether on this list or not, you can discuss this with your doctor. Simple reassurance may be all that is required, or it may be a lower dose or change to an alternative medication could be tried. Interactions with other medications. PPIs can increase levels of the antidepressants citalopram and escitalopram, which can lead to toxicity. They also raise methotrexate and warfarin levels. Methotrexate is a medication given for chronic arthritis and some cancers and can be toxic at high levels. Warfarin is an anticoagulant and should always remain in the correct range. Omeprazole and esomeprazole lower the efficacy of clopidogrel, a drug which reduces platelet stickiness, part of the clotting mechanism, and is given to vulnerable people to protect from blood clots causing heart attacks and strokes. Other PPIs can be used instead. PPIs can reduce the capacity to break down certain drugs, such as phenytoin, diazepam, carbamazepine, tacrolimus, and cyclosporin, leading to a rise in their levels. They may also have a similar effect with statins. The absorption of some antifungals, ketoconazole and itraconazole, may be reduced and require some dose adjustment. Your doctor will be aware of these and other interactions. Pharmacists are also an important group to help ensure interaction awareness. Are there any adjustments to dose required for other conditions I may have? These medications break down in the liver. If you are known to have a liver condition, only lower doses may be required. If necessary, you can discuss this with your doctor. Can I take a PPI if I am pregnant or breastfeeding? The answer to both of these questions is yes, you can. Now, what are the main learning points from today's presentation? PPIs are widely used, safe and effective medications to treat upper gastrointestinal acid-related problems. For most people, use is on an as-required basis or a 4 to 8 week course of treatment prescribed by their doctor. A few cases are more complex and may require assessment by a gastroenterologist. A few conditions are considered appropriate for long-term regular use. Apart from these, long-term regular use should not normally be needed unless specified by a gastroenterologist. Many patients remain on regular PPIs inappropriately. Main learning points continued. There are some potential problems with long-term use. This relates to osteoporosis risk increase, risk of chest and gut infections, unbalancing minerals and vitamins, and very occasionally kidney function decline. There are some interactions with other medications. If you do require to be on a PPI long term, your doctor can help you deal with these issues. For example, adjusting medications, arranging blood tests, and osteoporosis scans if appropriate. A link to dementia has been raised, but this remains very uncertain. Stomach cancer is not thought to have a causative link. You can address lifestyle issues to try to improve your symptom control. Other important issues are being aware of the temporary acid rebound effect on stopping PPIs and ensuring Helicobacter pylori has been checked for and treated, especially if ongoing symptoms. Thanks for watching my video. Please like and subscribe if you have found the presentation interesting and it has helped your understanding of this medication group. Feel free to leave a comment, including if you have any suggestions or questions. I think your feedback will be very valuable to help me grow my channel. Watch out for my up-and-coming presentations on different medications, including ACE inhibitors and statins.